Okay. Welcome, everyone. Thank you for joining us for today's webinar, Intro to Breast Cancer Part 1, Early Stage Breast Cancer. I'm Rebecca Armstrong, the Director of Patient Education and Engagement with the Canadian Breast Cancer Network. This session is being recorded and will be available on our website for anyone who may have missed it, and I'll send a link out once the recording is available. You will find all of our previously recorded webinars that address a variety of different breast cancer-related topics on our websites. I would like to extend our sincere appreciation to our sponsors for this session today, who have provided support through unrestricted educational grants. Novartis, our gold level sponsor, Pfizer and Gilead, our silver level sponsors, and Bayer, Tercera, AstraZeneca, and Lilly Canada, our bronze level sponsors. The format for today's session will be a presentation by our expert speaker, followed by a question and answer period. Please feel free to submit your questions throughout the session using the Q&A function. Our speaker today will do her best to answer your questions, but please note that she may not be able to speak specifically to individual situations without having a complete medical history. I would now like to welcome our host for today's session, Kathy Amendolia, the Chair of the Board for the Canadian Breast Cancer Network.
And thank you, Rebecca. Welcome again, everyone. Thank you for joining us today. I am pleased to welcome and introduce our expert speaker, Dr. Roochi Arora, who is a medical oncologist at Humber River Hospital with specialized expertise in breast cancer. Beyond her clinical practice, Dr. Arora is passionate about patients and family-centered communication. She is the author of Mommy Gets Cancer, a children's book designed to help families talk about a parent's cancer diagnosis, and is currently working on her second book in the series. Dr. Arora, it's great to see you, and thank you for being here today.
Hi, everybody. Thank you so much for having me. So why don't I share my screen and we can begin. Okay, can I just get a thumbs up that everyone can see? Okay, thank you. Let me just minimize this. Okay, so we will talk today about early breast cancer, and that's myself, Roochi Arora, medical oncologist. So we're going to review some background information on breast cancer. We'll talk about the multimodal approach to early breast cancer treatment, and we'll explore some future opportunities. And before I continue any further, I just wanted to say a thank you to Dr. Sadev, who did the talk last year and was kind enough to share some of his slides for me so that I could build upon them. So I don't think I really need to tell you guys why we should care about a topic like this. I'm sort of preaching to the choir here, but nevertheless, breast cancer is obviously a huge problem in North America and in the world. These stats come from the Canadian Cancer Society. So when it comes to all estimated cancer deaths in women last year, so breast cancer made up 13% of those. And in terms of new diagnoses, so a quarter of new cancer diagnoses in women are due to breast cancer. So clearly it's a very, very prevalent problem. And when we talk about some of the major risk factors for breast cancer, we sort of categorize them into those that are modifiable and those that are non-modifiable. So starting with the non-modifiable, so unfortunately, hard to change if you were born female and have estrogen in the body, but that's a major risk factor. Age is also, unfortunately, not something we can do anything about. Time only goes forward. And your family history. But there are some modifiable risk factors, including obesity, smoking, alcohol, and I didn't include it on there, but certainly certain hormonal exposures as well. So what exactly is breast cancer? So breast cancer is a bit of an umbrella term, and so it's really important that we actually understand exactly what we're talking about here. So one can actually have precancerous cells in the breast, meaning that they are abnormal cells that if they were left alone, they would one day become cancerous, meaning they would invade and have the potential to spread. But in and of themselves, on their own, they are not actually cancerous. They are not capable of spreading. And so that is where we see DCIS DCIS and LCIS. So ductal carcinoma in situ and lobular carcinoma in situ. And so ductal just basically means, if you look at this picture on the right, so it arises from the ducts here, which are these little fluffy glands, and then lobular meaning coming from the ducts here being these sort of pipe-like structures, and then lobular coming from the lobules, which are these fluffy-looking glands here, or lobes, as it's labeled on the image. And so in the same breath, while you can have precancerous cells of these structures, if it is left alone long enough, then those precancerous cells actually develop invasive potential and they become real cancers. And that's where we would say invasive ductal carcinoma or invasive lobular carcinoma. So when it comes to breast cancer, there are many, many different kinds of breast cancers, and we sort of categorize them in these different buckets. And this is important for multiple reasons, specifically when it comes to how are we going to treat this cancer, and what is the long-term outlook from this cancer. So we can categorize invasive breast cancers as hormone positive, HER2 negative. And this is where the cancer growth is largely fueled by the female hormones, estrogen and progesterone. Hormone positive and HER2 positive, or we may also call that triple positive. So the cancer growth often is largely influenced by the HER2 positivity, but there is, of course, an element of hormonal growth as well. HER2 positive, and it should say in brackets here, hormone negative, because that's really what we're talking about. So largely influenced by HER2, and then triple negative breast cancer, which is sort of this basket term that's sort of like just everything else. You can throw it in that category. And that's not influenced by HER2 or hormones or anything. It sort of has its own mechanism. And sometimes there are different kinds of triple negative breast cancer, even within that one category. And then there's these HER2 lows, which we won't talk too much about today because it's still sort of emerging in terms of its role when it comes to treatment. So when we look at, again, these different subtypes of breast cancer, we categorize them based on the hormonal profile. So when we talk about, so there's two types of hormone positive, HER2 negative breast cancers, luminal A and luminal B. So the luminal A's tend to be very strongly hormone positive, or the luminal B tends to be less strongly hormone positive. And this is important to know because the luminal A's tend to be a lot more slow growing, low grade, low Ki67, which is essentially a marker of how fast the cells are growing. And therefore the treatment tends to focus on the endocrine pathway or the estrogen pathway, and the prognosis tends to be good. And as you move down, you get more luminal B or luminal B-like. These tend to be more high-risk breast cancers that tend to require, in addition to endocrine therapy, often chemotherapy, HER2 treatment if it's HER2 positive, and then the prognosis is not quite as good. And then we get into these, HER2 enriched hormone negative ones, certainly much more high grade, high risk of recurrence, and we're using chemotherapy for these people. And then it comes down to what we would consider the highest risk breast cancer or the poorest prognosis, which would be triple negative breast cancer, which tend to be high grade, high Ki67, and need chemotherapy. Now, I will say, I don't want to put a damper on anything. There are lots and lots of advances in the world of treatment that are moving the needle forward and improving prognosis overall, and we're certainly going to talk about those today. But by and large, this tends to be how we think about the groups of breast cancer. And this is just really another way to sort of show that. So in terms of what is most common, so typically we are seeing luminal A and luminal B most common. HER2 positive tends to be in about 10 to 15% of cases, and then the triple negative we're seeing in about 15 to 20% of cases. Okay, so let's just talk briefly about staging. I don't ever focus too much on staging because it's sort of a very arbitrary thing. And you can look at staging in terms of what's called anatomic staging, which is purely based on the size of the tumor and whether or not there are lymph nodes involved. But there are also ways to look at staging in terms of taking into account molecular characteristics, hormone receptors, grade of the tumor, etc. So for simplicity, we're just going to talk about the anatomical staging in very brief terms. So one could have, as we talked about, in situ, so ductal carcinoma in situ, for example, and it's just precancerous cells that are just confined to the one area in the breast, and they've not developed any capacity to invade further. Stage 1 breast cancer basically involves a small tumor, so less than 2 centimeters, and I would say no lymph nodes involved in that case. A stage 2 breast cancer is usually a little bit of a bigger tumor, so typically in the range of 2 to 5 centimeters. And then often, but not always, there's potentially a lymph node involvement. And then, oh, for some reason, stage 3 was not on there. But essentially, bigger tumor, potentially more lymph nodes involved. And then stage 4, by definition, is metastatic, which means it has spread to other organs in the body. So the reason staging is relevant and important is because it influences survival and it influences the risk of recurrence. And if somebody has a higher risk of recurrence, we're going to be more aggressive with how we treat them to try to lower that risk of recurrence. So if someone has a low risk of cancer recurrence, anything we do to them is only going to have small amounts of benefit. But if somebody has a really high risk of cancer recurrence, you better believe we're going to stack as many treatments as we can to bring that risk down as much as possible. So this is sort of showing you all the different cancer types, but if you just focus here on female breast cancer, so it is probably not surprising to see that stage 1 over here in the blue has the best survival, and then it's a little bit less when it comes to stage 2, and then stage 3 and stage 4, it sort of goes down as you go across. And I just wanted to make a note on something, which is what we call late recurrences. So in many different types of cancers, so I treat a lot of different types of cancers where I work. Often we are talking to patients about these 5 years, these sort of 5 golden years we need to get through. And if the cancer doesn't come back after 5 years, we often graduate patients from our clinic and we tell them that almost certainly your cancer is not going to come back. Unfortunately, with breast cancer, and pretty specifically with hormone positive breast cancer, we can't quite say the same thing. So this study here, this is one of the older studies from the EBCTCG group, Early Breast Cancer Trialist group, and they basically looked at risk of late recurrence, so 20 years after stopping endocrine therapy. So if somebody took their adjuvant hormonal therapy for 5 years and then stopped, and then they looked at 20 years out, what was the risk of cancer coming back? And there is a risk, unfortunately, and that risk does depend on risk factor, on how high risk the cancer was to begin with. But even so, if you look at the yellow line here, so that's N0, meaning no lymph nodes involved, at 20 years, there was still actually 22 recurrences, 22% chance of recurrence. And then when we look at higher degrees of lymph nodes involved, those risks just go up and up with time. And the theory behind that, as we were discussing, so luminal A cancers specifically are those ones that are a little bit slower growing. The cells can hibernate in the body and they can kind of go to sleep for sometimes many, many, many years. And sometimes those cells will wake up and patient will be in those 5 years of anti-hormonal therapy. The cells will be awake, they're trying to grow, but they can't grow because there's no food being estrogen, progesterone, so the cells die. But sometimes those cells are so slow growing that they can hibernate for a really long time, like 10 years or 15 years. And then down the road, they wake up. And unfortunately, these recurrences can occur way down the road. Okay, so when it comes to not just breast cancer, but really any kind of cancer, there's sort of 2 big questions we ask when we're diagnosing somebody and we're trying to come up with a treatment plan. And so those 2 questions are, what is it and where is it? So addressing the first question, which is, what is it? So really this comes down to let's make a diagnosis. So how do we make a diagnosis of breast cancer? So typically, I should have included on here clinical exam because that is certainly a part of it as well. But essentially, cutting to the chase, we need a mammogram. Sometimes we do an ultrasound, sometimes we do an MRI. But at the end of the day, the end all and be all is to get a biopsy. So we need a breast biopsy of the mass itself so that we can confirm the diagnosis. And then addressing the second question, which is where is it? So this actually largely depends on the features of the breast tumor itself. So if it is a small tumor with no lymph nodes involved, that's considered a stage 1 tumor. And there's actually no role for any further investigations. If it's a little bit of a bigger tumor, these are sort of old guidelines from Cancer Care Ontario, but they did used to say that if it was a stage 2A, a bone scan could be done. Now the new thing is PET scan. So a stage 2B or a stage 3 breast cancer, those patients qualify for a PET scan. And the purpose again is basically to look for, is there any other place where this cancer exists in the body? Okay. So we're going to focus most of our discussion around treatment. And because this is a talk all about early breast cancer, I think it's very important to emphasize here that the goal of treatment is to cure this cancer. Okay. So there are many components of treatment for breast cancer. And me being a medical oncologist, I'm really going to be focusing on these last two here, systemic treatment and immunotreatment. However, surgery is, of course, an important part of the treatment of breast cancer, as is radiation. So we will briefly touch on those. So I really like this analogy. A physician I worked with many years ago when I was finishing my training used this, and I use it often with my own patients as well. So this is a weed inside of someone's lawn. And the way that I describe it to my patients is because sometimes people ask me like, well, can I just do the chemo and not do the surgery, or can I do the radiation and not the chemo? And so, people sort of sometimes wonder if it's a bit of an a la carte menu, whereas we're trying to sell this as a total package often. So if you think about your lawn and there's all sorts of weeds all over it, doing surgery on breast cancer is like pulling the weed out of the ground. Okay. And doing radiation to the breast and potentially to the armpit is like burning the root of the weed so that it doesn't grow back in that spot where you just pulled it out. Okay. And then doing whether it's chemotherapy, endocrine therapy, or some combination or any other systemic treatment, meaning treatment that goes through the whole body, that is like spraying your entire lawn down with pesticide so that you don't develop more weeds in other places in the lawn. Okay, so hopefully that analogy makes sense. Okay, so just very briefly, we'll just talk about surgery. So surgery, pulling the weed out of the lawn, very, very important part of treatment of breast cancer. So typically we're looking at either a lumpectomy or a mastectomy. Sometimes, most times, patients have the option, but sometimes if the tumor is not easy to resect and leave enough healthy tissue behind, a surgeon may say that mastectomy is the only option. So lumpectomy often preferred by patients because it's less invasive and often they can get a better aesthetic outcome. The downside to it is that typically, pretty much all the time, radiation is needed in addition to the lumpectomy. There is potentially a slightly higher risk of recurrence, and patients have a bit more anxiety because the breast is still there. I think when the breast is gone, there's a sense of, it's not going to grow back there. Mastectomy, on the other hand, so lower risk of recurrence, less need for, and I should mention, not just lower risk of recurrence, but also lower risk of another breast cancer forming in that same breast. Less need for radiation, although not necessarily the case that they never need radiation, but less likely to need it. And you don't need a mammogram if you don't have a breast. So often patients may have a unilateral mastectomy, so they only removed the breast that had the tumor in it. So the other side would still need mammograms for the future, but at least the side that you had a mastectomy, you don't need a mammogram. And the cons are, of course, the aesthetic component, and there's a little bit longer recovery. Okay, radiation. I will not even pretend to be an expert in this area because radiation is a field in and of itself, and it's definitely complex. But what I will say is that radiation essentially uses energy beams and lasers to kill any microscopic cancer cells that may exist in the local regional area. So typically that's the post-operative bed where the tumor was removed, and then also in the regional area, meaning the armpit. And I know that radiation has come a long way in terms of techniques that have allowed the radiation oncologists to overall often give less radiation. So a few years ago, when I was still finishing my training, pretty much all the patients were going for somewhere in the range of 20 to 25 sessions, so 4 to 5 weeks. And now many, not all, but many patients are able to get away with significantly less, sometimes only 5 sessions, sometimes only 15 sessions. So there have definitely been a lot of advancements in the field to reduce the burden of treatment. But unfortunately, that is the extent of my knowledge of radiation. Okay, so let's talk and focus on systemic therapy. So this is what I do. I treat patients with medicines, whether those are IV, whether they're injections, or whether they're pills. Okay. So when it comes to systemic therapies, systemic means goes throughout the entire body. So the questions really are who needs it? And really it's the people who are at higher risk of recurrence who need it. And then what type of treatment do they need? And that is going to depend on the type of breast cancer it is, as well as their risk of recurrence. So as we talked about before, if somebody has a very high risk of recurrence, we're going to try to throw everything at them to lower the risk of recurrence, versus if they have a low risk to begin with, then we are a little bit more cautious and careful because they probably are not going to benefit from all of the aggressive treatments we have. Okay, so you may or may not have seen this before. I use this a lot with my patients when we are making some decisions around treatment. So this comes from a website called UK Predict, and basically it allows you to put in the characteristics of your patient and their tumor, and ultimately help you determine what is the exact benefit in terms of survival advantage to doing all of the interventions, as in chemotherapy or hormonal therapy. Okay, so as an example here, I just put in a 55-year-old postmenopausal woman whose tumor was estrogen positive, HER2 negative. Typically at our center and most centers, Ki67 is not really reported, so I usually just put unknown. And let's say that this woman had a 3.5 centimeter tumor that was grade 2, found by screening. And she had one lymph node that had cancer in it, okay? And so when you compute these results, you can select if we put this woman on 5 years of hormone treatment, and then if we give her chemotherapy. And so you can look at the results here, which basically tell you that the chances of this woman being alive, very important to understand, alive, but not necessarily cancer-free. This only tells you if the patient will be alive or not. It doesn't tell you if the cancer is going to come back, but they are still alive, okay? So chances of this woman being alive in 10 years, if all she did was surgery and that's it, no chemo, no hormonal treatment. If all she did was surgery, that's those dark blue dots here. So 77% chance, okay? If she accepts doing hormonal treatment, that's those light blue spots here. So there's 5 extra percent advantage to being alive in 10 years. And then if she accepts doing chemotherapy, if it is warranted, then an extra 3% chance of being alive. Okay. So you can really kind of add up the benefits in terms of reducing the risk of death related to the breast cancer. But once again, this is limited because it doesn't tell you about the risk of cancer coming back and being alive and living with metastatic breast cancer, which is most people would prefer not to be in that scenario. Okay, so let's now talk a little bit more specifics about each of the types of breast cancer so we can go into some details around treatment. So we will start with hormone positive, HER2 negative breast cancers. So tamoxifen is sort of our very old school first treatments that was ever developed in the world of hormone positive, HER2 negative breast cancer. Interestingly, it was actually developed as birth control. However, it did not work well as birth control, and very unfortunately, it caused a lot of birth defects. So I tell all my patients who are on tamoxifen and anywhere in the vicinity of potentially being able to have a baby, that they must not get pregnant because it can cause very serious birth defects. So the way that tamoxifen works is it's something called a SERM, selective estrogen receptor modifier. So basically what tamoxifen does, so if you look at these little yellow receptors here, these are estrogen receptors in the surface of a cell. And these little yellow dots here are estrogen. So estrogen typically binds to its receptor and activates this entire pathway. Tamoxifen kicks estrogen out of here and it blocks it. So it binds to this receptor instead and basically shuts the whole pathway down. So now estrogen is not able to act on this receptor. Now it's a little bit of an interesting medication in the sense that when it comes to breast cancer cells, that's what it does. It blocks the whole pathway, so the cell basically dies. But on other tissues, tamoxifen can actually act a little bit like estrogen, almost like a bigger dose of estrogen. So for example, in the endometrium, the endometrial lining, which is sensitive to estrogen, tamoxifen can bind and it can turn on the pathway even more. And as a result, one of the potential risks of being on tamoxifen is something called endometrial hyperplasia, which is essentially extra growth of the endometrium. And we'll talk a little bit about that very rare, but scary potential side effect, which would be endometrial cancer. So we know that tamoxifen works well in terms of reducing risk of breast cancer recurrence. This data is very old now because we have so many more interventions in the space of anti-hormonal treatment. But if you just look at one of these very old school, first studies that were evaluating how effective tamoxifen is in estrogen sensitive HER2 negative breast cancers. So if you look at 10 years, if all the patients took tamoxifen, and at this time they were only taking it for 5 years. So after 10 years, the risk of recurrence, if they took tamoxifen, was 24.8% versus 37.7% if they didn't take tamoxifen. So that's a big difference. And even at 5 years, there's a big difference of 11%, whether they took tamoxifen or didn't take tamoxifen. So side effects. I think it's really important to be thoughtful and cautious when we talk about side effects, because if I were to give a patient a handout on the side effects of Tylenol, it would be just as long in terms of the list that we're seeing here. So there are many things that could happen, and you can read all about them here. But practically speaking, the things that we tell our patients about. So the common things would be menopausal symptoms like hot flashes. If patients do get that, there are some options like venlafaxine, which is Effexor, or gabapentin, or oxybutynin. There can be some changes to the vagina, sometimes some discharge, or more commonly, I see dryness. There is a slightly increased risk of blood clots. It's about 1%, pretty much the same risk as if someone was on oral contraception. And we talked about uterine or endometrial cancer. So that's quite rare. But nevertheless, we tell all our patients, if you develop any abnormal vaginal bleeding on tamoxifen, very important to stop it and to call us so that we can evaluate them further. There are some benefits to tamoxifen as well. So as I had mentioned, there are some tissues where tamoxifen acts like estrogen. So as a result of acting like estrogen, it can have some very positive effects. So there's actually less heart disease and lower cholesterol. And for those women who are older than the age of 50, where they're often losing bone mass due to perimenopause and menopause, tamoxifen acts on the bones and actually improves the health of bones and the strength of bones. So the other major anti-hormonal treatment option is a group of medicines called aromatase inhibitors. So there are different kinds. We call them cousins of each other: exemestane, anastrozole, letrozole. You may know them as, Arimidex or Femara. So these are other types of anti-hormonal treatments. And so instead of working on the estrogen receptor, they actually work inside of the cell, and they block the enzyme in the cell that basically synthesizes estrogen. So in postmenopausal women, even though their ovaries are no longer working to make estrogen, fat cells still synthesize estrogen, which is in part why one of the recommendations is weight loss and not gaining weight when trying to prevent recurrence of breast cancer. In a premenopausal woman, if the ovaries are still functioning, we must not use aromatase inhibitors, because if a patient takes an aromatase inhibitor, there will be a temporary drop in estrogen synthesis. And so her brain will basically read that there's lower estrogen, and it will send signals to the ovaries to basically ramp up estrogen production. Okay, so what is better, aromatase inhibitors or tamoxifen? So keeping in mind that in premenopausal women, if you don't make them menopausal, then you cannot give them an aromatase inhibitor. They can only get tamoxifen. So consistently, we do find that there is a slight advantage in terms of risk of recurrence. So you can see here 19% versus 22%. So it's about 3 to 4% benefit in terms of lower risk of recurrence if a patient gets an aromatase inhibitor versus if they get tamoxifen. Out of all the studies that have been done and all the years of follow-up, I don't believe, to the best of my knowledge, that we have ever actually demonstrated that there's a survival advantage to taking an aromatase inhibitor over tamoxifen. But there is an ever so slight lower chance of recurrence, which is why most of us tend to prefer using an aromatase inhibitor as the first option for our postmenopausal women. However, the difference is not so great that if a woman is running into troubles on aromatase inhibitor, or if there are, some of those side effects that are concerning, for example, bone loss, we would go ahead and switch to tamoxifen. We would not, poo-poo it as a good option for treatment of breast cancer recurrence, or prevention of breast cancer recurrence, I should say. And then there is a strategy, which is basically to switch. So what one could do is start with an aromatase inhibitor, with tamoxifen, and then switch sort of halfway through to an aromatase inhibitor. And it appears that if you take that approach, the outcomes are pretty much the same versus if you stay on an aromatase inhibitor for the entire time. So how long to be on these medications is kind of hotly debated, and it depends a lot on the risk to begin with and if someone needed to get chemotherapy or not. But by and large, we typically recommend a minimum of 5 years, but there is some discussion that in certain patients, initially we thought 10 years was probably better, and then now we've sort of settled on 7 is probably the sweet spot. Between 7 and 10 years, there doesn't really seem to be much added benefit. So a lot of patients who, for example, are, let's say, 49 or 50, kind of at the cusp of menopause, but not technically menopausal, we can give them tamoxifen for about 3.5 years, roughly, or 3 years, whatever, and then we can switch them to an aromatase inhibitor for the remaining 3 to 4 years. And they have the same outcomes as someone who would have been on an aromatase inhibitor that entire time. Side effects of an aromatase inhibitor. So again, if you look at the actual, monograph, you're going to read about tons of potential things that it could cause. However, practically speaking, the things we talk about, hot flashes, not surprising, vaginal dryness. In recent studies, it appears that using a local estrogen cream is okay. It's usually not our first choice, but if it's what's necessary, then it's typically okay because there's almost no systemic absorption of an estrogen cream. The big one or one of the big ones, I should say, with aromatase inhibitors is reduction in bone density and risk of fractures. So the risk is small overall, but we do speak to all of our patients about reducing risk of fractures. So taking vitamin D, trying to eat enough calcium in their diet, and then exercise. And when it comes to exercise, the focus is really on weight-bearing exercises. So things like walking, skipping, jogging, and resistance training, so lifting weights. Swimming is a great exercise in terms of weight loss and cardio, but it is not weight bearing. So you have to actually have your feet on the ground and have a load on the body. And then in terms of joint and muscle pain, so a lot of our patients will feel very stiff in the morning, achy, and it's often the small joints. So like the fingers, the wrists, the ankles, can sometimes be in the knees as well. And there are things patients can try. They can try Tylenol, occasionally ibuprofen, or Voltaren gel. Often exercise actually tends to help in these cases. And I would say in my experience for many, though not all patients, it does improve over time. I tell most of my patients it's really the worst in the first 3 to 6 months. And then after that, it tends to improve quite dramatically. Um, if there is no improvement or if it's really, really problematic for patients, then we tend to just try a switch to one of the cousins. And often, again, but not always, that can lead to an improvement in symptoms. If it doesn't, then we often think about switching to tamoxifen. Okay, so the other important component of anti-hormonal treatment is what to do in a premenopausal woman. So there are times when a premenopausal woman should be made postmenopausal. So premenopausal women, their ovaries are working, hence they're making estrogen. Um, if often premenopausal women have slightly higher risk breast cancers to begin with, a lot of those women, not all, but a lot of them do end up getting chemotherapy. If the chemotherapy puts them into menopause and their periods don't come back, that's actually a better prognosis overall because their estrogen is not starting to rise again. However, things can be unpredictable. Sometimes the periods can stop and then they can actually come back later. And so we want to kind of manipulate that pathway to try to keep the estrogen and progesterone down for as long as possible. So inducing early menopause has a better prognosis for these patients. And as we talked about, allows us to use aromatase inhibitors. So you can only use them in a postmenopausal woman, whether she naturally became menopausal or she was put into menopause through medications, which we talk about here. So medications like Lupron or Zoladex, which are dosed every either 1 month or 3 months, or just removing the ovaries. So this strategy is what we call ovarian function suppression. And the reason it is so beneficial is because by lowering the estrogen, you can then put these patients on an aromatase inhibitor, and that seems to have the best outcome overall. So exemestane was the one used in the studies. Exemestane plus ovarian function suppression seems to have the best outcome overall in terms of reducing risk of cancer recurrence. Tamoxifen and ovarian function suppression also appears to improve risk of recurrence. So things like distant disease-free survival, distant recurrence. In kind of the general population, it hasn't showed overall survival versus tamoxifen alone. However, in high-risk groups, so specifically grade 3 tumor or patients who are less than the age of 40, there is some survival advantage to taking exemestane plus ovarian function suppression. And it's important to understand that part of what underpins all of our decisions around, being really aggressive, like sounds very aggressive, right? Like forcing a woman into menopause who's potentially in her, her 30s, is that late recurrences often occur. So as much as possible, we really want to lower the risk of recurrence and kill off any of those cancer cells in those first few years. But unfortunately, it's still possible to have a late recurrence beyond 15 years, especially if a patient was younger to start with. Now, the one caveat to this is that the studies, so these were the soft and text studies, the studies on ovarian function suppression were done when we did not have Oncotype DX testing, which we're going to talk a little bit about in the coming slides. So, Oncotype DX testing has overall allowed us to use less chemotherapy. So, patients who were traditionally considered higher risk based on, size of tumor and lymph nodes and grade, sometimes the Oncotype DX testing allows us to avoid chemotherapy in those patients. So, we don't know then if those patients would still benefit from the same approach, because by and large, our approach has been to use ovarian function suppression in those women who were high risk enough to need chemotherapy. Okay, so let's talk about chemo. So who needs it? What kind of chemo do they need? And how many cycles of chemo do they need? So in terms of making a decision around who needs chemotherapy, so we often turn to a test called Oncotype DX. So this is great for early stage hormone positive HER2 negative breast cancers where there are up to 3 lymph nodes involved. Not everybody needs this test. It's certainly on a very case by case basis. If I have a young woman who's premenopausal and has a very large tumor, or has, a tumor and 1 or 2 lymph nodes involved, technically she qualifies for Oncotype DX testing, but I probably would just recommend chemotherapy to her anyways. Even if the oncotype came back, low or in a gray zone, I would probably still make that recommendation. So it's certainly not recommended for not universally used for all early stage hormone positive breast cancer patients, but it is a tool to help us, to help guide whether chemotherapy is indicated or not. So one of the earliest studies on the Oncotype DX testing, basically, so this test, for anybody who doesn't know, will essentially involves taking the tumor, sending it to California, and then doing fancy testing on them under the microscope. And multiple genes are assessed, and the risk of recurrence and the chances of benefiting from chemotherapy are reported. So the scores can be anywhere from 0 to, I think they can even go all the way to 100, but the study here, they only looked at up to 50. So basically, a score of greater than 25, those patients certainly benefit from chemotherapy. Less than 11, there was no benefit. So there was this gray zone of 11 to 25. So then that was further analyzed through this other study, Taylor X. And essentially what was found was that at least for postmenopausal women, there was no benefit in giving chemotherapy if they had a recurrence score of 11 to 25. The caveat is in the 21 to 25 group in premenopausal women, there is potentially some benefit there. So we do discuss it with those patients. Okay, so that is one of the ways how we make the decisions around whether or not to offer chemotherapy. So what kinds of chemotherapies do we actually use? So most of the regimens are either taxane based or a combination of anthracycline and taxane based. So anthracyclines, a class of chemotherapy medicines, so common ones being doxorubicin, epirubicin. You've probably heard of the red devil before, so that's doxorubicin. So these were originally derived from fungi. And taxanes, so common ones being paclitaxel or docetaxel, these drugs were originally derived from the yew tree. So I know it is very preferred to be as natural as possible in today's day and age, especially. So you can rest assured that these medications once came from very natural sources. So we can talk about chemotherapy in terms of being second generation or third generation. So second generation chemotherapy does not include an anthracycline. So a very common regimen would be TC for 4 cycles. So T being docetaxel, C being cyclophosphamide, and we would give that for 4 treatments and then you're done. A third generation option is one that includes an anthracycline. So common ones being FEC-D, FEC-D or T in this case, or Dostence ACT. And these ones are a little bit longer. So by and large, general side effects of chemotherapy, so hair loss, nausea. I will say, and I tell most patients that nausea was a big deal in the past, not quite as big of a deal anymore. But nonetheless, it is still an issue for some patients. Not as big of a deal anymore because we have very good antiemetics, anti-nausea medicines that we have created a regimen for patients to take before and after treatment. So if you sort of follow the regimen as prescribed, there's actually very little nausea overall. Taste changes are common, fatigue. The big one that we worry about is low blood counts and in particular low white blood cells, which can rarely lead to life-threatening bacterial infections. Mouth sores, bowel changes, aches in the bones, neuropathy, so numbness in the fingers and toes, which certainly can be a problem depending on somebody's sort of employment. And then some rare, scary things. So I've never seen it before, but technically there is a risk of leukemia secondary to chemotherapy, and anthracyclines do carry a risk of damage to the heart. So the new thing now, in terms of adjuvant treatment, so preventative treatment, is to be doing CDK4/6 inhibitors. So you may have seen some of these medications in the metastatic setting, and they've now been studied and have kind of moved up for use in what we call the adjuvant setting. So I'm not going to talk too much about abemaciclib. The most recent one is ribociclib that has just been approved. So this was based on a study called the Natalie trial, and essentially it involved patients who had hormone positive, HER2 negative early breast cancer, and they had to be at least stage 2A. They could be stage 2B or stage 3. So the bottom line is they had to be high risk enough, but not so high risk as the patients who had to qualify for abemaciclib. So they could still be lymph node negative as long as they had some other high risk features. So like a high risk oncotype score, for example, or a high risk Ki-67 score. So the patients were then randomized to basically get either letrozole or anastrozole alone, or to get letrozole plus ribociclib, and then they looked at kind of the outcomes from there. And the bottom line, so in both premenopausal and postmenopausal women, the bottom line was that overall there was an improvement in what we call disease-free survival. So basically the chances of being alive and cancer-free. Right now, a lot of the data is still early, so the numbers are small. So this difference of sort of 5% or 4.6% may look small, but as time goes on, these differences may become more and more apparent. Okay, so the sort of conclusion from that is that ribociclib plus an aromatase inhibitor does provide benefit across a broad range of patients with intermediate to high risk stage 2 or 3 hormone sensitive HER2 negative early breast cancer, whether the patient's premenopausal or postmenopausal. And overall, the side effects are manageable. Okay, so I am now going to switch gears and we're going to talk a little bit about HER2 positive breast cancer. So trastuzumab is the key antibody that has probably been one of the biggest advances in breast cancer over the last many, many decades. So trastuzumab is a monoclonal antibody that basically works on the HER2 receptor in combination with chemotherapy. So HER2 positive breast cancers have this problem where on the surface of their cells, there is a receptor called HER2 that is overactive and overexpressed. And when that happens, when it's overactive and overexpressed, it causes the cells to grow and divide like wildfire. So HER2 positive breast cancers, classically, my patients tell me it's like this tumor popped up overnight, because in a way it kind of did. Like they just grow so quickly. And for the longest time, before we had trastuzumab and monoclonal antibodies, these cancers actually had the worst prognosis, and now they actually have some of the best because of the advances in treatment. So by and large, other than for some really small early stage 1 HER2 positive breast cancers, for most patients, we are considering them for neoadjuvant, meaning before surgery, combination chemotherapy plus trastuzumab, that antibody. So this can be in combination, something called TCH, so that would be docetaxel plus carboplatin plus H is Herceptin, which is the other name for trastuzumab, over 6 cycles, or dose-dense ACT, which is a common regimen we talked about before, and then just adding in the trastuzumab in the latter half of it over 8 cycles. So what about neoadjuvant pertuzumab? So you might be wondering, what even is pertuzumab? So pertuzumab is just another monoclonal antibody that also binds to that HER2 receptor, but it just binds in a different location. So it can work in combination with trastuzumab to basically shut down those HER2 positive cancer cells. So there was a study that was done called the NeoSphere trial that basically looked at using trastuzumab and pertuzumab with chemotherapy in the neoadjuvant setting, so before surgery. And what they found, so this group here is the one that got chemo, the D is docetaxel. So chemo plus trastuzumab plus pertuzumab. And so PCR is, we'll talk about on the next slide, but basically it means that all the cancer disappeared by the time of surgery. So the highest PCR rates were achieved in those patients, whether ER positive or ER negative, in those patients who got both antibodies, okay, versus if they got just the trastuzumab, lower rates of PCR, or if they got just the pertuzumab. So we want to achieve a PCR. We really want it to be the case that patients go to surgery, all the cancer has disappeared. And as much as we want that, unfortunately, pertuzumab is not actually funded in the neoadjuvant setting, and that's because it's not really shown any overall survival benefit. So outside of Quebec and other countries, it's not funded. So it's definitely not funded in Ontario. So it is a complex discussion. Sometimes if patients have private insurance or things like that, we can consider it. Most of us would actually like to add it preoperatively if we could. And again, it's because there's a better chance of a complete response or pathologic complete response. So if a patient gets a pathologic complete response, one, it's better for them in terms of lower chances of recurrence down the road. Two, there's a better chance of being able to get a lumpectomy versus a mastectomy if that was a concern in the beginning. And three, the other big advantage is that if you get a pathologic complete response, after your surgery is done, we can continue you on just that treatment. We don't need to intensify the treatment after that. And this basically just shows that when you look at recurrences and recurrence-free survival, so if a patient has a PCR or just a little stage 1 breast cancer, the outcomes are the best versus if what we call residual disease, so the cancer remaining after surgery, if there's more cancer remaining after surgery, that's overall not as good. And it seems to correlate with survival as well. So the highest survival is in those who have the PCR, and then it tends to go down over time if they had any residual disease. The more residual disease, the worse the survival, unfortunately. So what can we do for those people who have some residual disease, did not get a PCR? So if they got a PCR, we just continue with the trastuzumab, and if they got pertuzumab, continue that too for the remainder of 1 full year. Okay. If they did not get the PCR, those are the ones who are higher risk of recurrence, of bad outcomes. We will switch, or we will consider switching after their surgery to a medicine called TDM1 and continue that for the remainder of the year. So TDM1 is a different antibody. It's called trastuzumab emtansine. So it's essentially what we call an antibody drug conjugate. So it is the trastuzumab antibody, but it is linked to a chemotherapy type of molecule, a cytotoxic agent called DM1. So as you can imagine, it's going to have some chemo side effects, which we do unfortunately see. So a fair amount of neuropathy with it, as well as affecting the white blood cells and sometimes some bone aches and not common, but occasionally some nausea. So why we do this is really this trial that came out now a number of years ago, 6 years ago, almost 7 years ago. So the Catherine trial. So I remember when this came out, it was very practice changing. And basically what they found was that if you looked at the patients who, so this graph shows the patients who did not have a PCR. So they did have some residual disease. If you compare those who got trastuzumab after surgery versus those who got upgraded to TDM1, the invasive disease-free survival, so being alive and cancer-free at 5 years or 60 months down the road, was higher. So that is the rationale for it. So here, 77% versus 88%. Okay, so that is, in a nutshell, what we need to know about HER2 positive. So finally, touching on our last cancer type, which is triple negative breast cancer. So as I mentioned at the beginning, triple negative breast cancer is a little bit of a grab bag. It's kind of just everything else lumped into the same category. And I don't love that because yes, a lot of triple negative breast cancers are bad and they are the highest risks of recurring, but there are also certain other subtypes that are actually not as high risk. And so anyways, it does get a bad reputation, sometimes for good reason, but they're essentially all lumped into this same category. So if you look across the cancer types, so luminal A, that's the really low grade, strongly hormone positive versus luminal B versus HER2. So the survival is sort of lower with each subsequent type, and by and large, it's the lowest if you look at the HER2s as an entire class. Sorry, I think this is the same slide. Okay, so in terms of triple negative breast cancer, so we used to, way back when, the approach used to be just do surgery and then give everybody chemotherapy afterwards. If they were triple negative, they should get chemotherapy afterwards. And then what kind of chemo? Initially, we would just give them all the chemo we had, dose dense AC paclitaxel. And then we started to realize that platinum drugs uh, gave us a little bit of a boost in terms of better outcomes. So then we started adding that in. And then we saw that giving the chemo before surgery was probably a better idea. So we would give the chemo first and then do surgery and then maybe consider a medicine called capecitabine afterwards. And now the newest thing, as things have evolved over time, is actually immunotherapy. So we'll talk a little bit about this, but essentially now we're doing the chemo and the immunotherapy, then going for surgery, and then figuring things out after that. And triple negative is the one type of breast cancer that is most highly associated with BRCA mutations. Not that other types can't have it, but it is most commonly associated with triple negative. And so there are medicines called PARP inhibitors that can be used there as well. We'll talk about those. So just to briefly touch on this study called the CREATE-X study. So as I mentioned, what we used to do is we would give chemo first and then send somebody for surgery. And if everything disappeared after the surgery, great, that was the pathologic response. It didn't happen that often. If the patient did not have a pathologic response, so right over here, pathology, non-PCR, then they would either just be sort of monitored and that's it, or they would get capecitabine afterwards. So that's capecitabine is another type of chemotherapy. And what was found was that in this, actually this original study wasn't just triple negative breast cancer patients. It was actually all, it also included hormone positive breast cancer patients. So for those, the standard therapy was the anti-hormonal therapy. But ultimately what was found was that in the triple negative breast cancer subset, there was benefit in giving capecitabine after surgery if they did not have a PCR. So those patients did better than the control, as you can see here with the blue line versus the red line. So that's what we used to do. Now, after this other very large seminal trial came out, looking at the role of immunotherapy, which we're going to talk about, our approach has changed. So now we do a combination of chemotherapy plus immunotherapy. So multiple chemo agents, carboplatin, paclitaxel, pembrolizumab, which is immunotherapy, for 4 treatments, 4 cycles. And then we do AC, adriamycin, cyclophosphamide, and pembrolizumab for another 4 cycles. This is very long. If anyone's been through this, this is 6 months. And the first 3 months, you are getting treatment every single week. So it is a very long marathon to get through. But the outcomes are good. So this is just one of the updates. It's a little bit old now, but basically what they found. So event-free survival basically just means being alive and event-free. So, you know, no recurrence or things like that. So when they looked at after, this is actually still pretty early. We hopefully will have some longer term data soon, but even looking at just after 3 years, almost a 10% difference in terms of event-free survival for the patients who got the immunotherapy plus chemo versus just the ones who got the chemotherapy. So what exactly is immunotherapy? So immunotherapy is very different from chemo. Chemo is like trying to find the cancer cells and just kind of beating them to death. And then some of the normal healthy cells unfortunately get hurt in the process. Immunotherapy is basically teaching the body's immune system to recognize abnormal cells and then kill them off. So unfortunately, immunotherapy can cause any side effects from head to toe, which is essentially inflammation of any part of the body. I won't go into too much detail, but those are the main toxicities. And then finally, I know we're running short on time. So finally, PARP inhibitors. So PARP is a pathway that is closely linked with BRCA. So these are pathways that are involved in repairing DNA. So suffice it to say that if somebody has a mutation in BRCA, this is what Angelina Jolie had. So if they have a BRCA mutation, their ability to repair their DNA is compromised. However, they can still propagate those cells because there's sort of enough good DNA in there that the cells can keep growing and thriving, but they're propagating with all sorts of mutations, and that is where cancer comes about. This is why these people are at such high risk of cancer. So if you give them a PARP inhibitor, you're basically shutting down the other way of repairing DNA. So now there's all this DNA damage that happens and the cells can't survive and they just die. So that's what we do. We often give these patients PARP inhibitors if they have BRCA mutations. So adjuvant treatment for triple negative breast cancer. So we talked about immunotherapy. It's a little bit unclear now if there really is much value to giving capecitabine because that was studied in the era where we didn't have immunotherapy. And then olaparib, which is the PARP inhibitor, where exactly should that be in all of this? Should it be with the pembrolizumab? Should it be after the pembrolizumab year is done? Those are still, and then again, the study on the PARP inhibitor did not include immunotherapy. So there are still some questions that we're trying to sort out what is the right answer for them. Okay, and that is it. And I just wanted to, before I take any questions, I just wanted to make a little plug for my book. I wrote this book. It was a sort of a labor of love. I am very passionate about all kinds of cancers. And I was really recognizing that a lot of my young patients were having a difficult time talking to their kids about the diagnosis of cancer and trying to hide it. And I could see how much stress it was causing them. So that actually is where the inspiration came about for writing my book, which is a way for parents to be able to talk to their kids about cancer. And it's not specific to breast cancer or any type of breast cancer. So I hope if you or somebody you know may benefit from it, please do look into it. And that is it. I'll stop sharing my screen.
Thank you so much, Dr. Arora. That was wonderful. Lots of information, and I guess the listeners are going to take what they need based on their diagnoses if they're listening because of this. And the book, awesome. Very good. Very nice for you to put that book together, and it's very important. I'm going to go back to risk factor, your first page. And so there's a lot that people discuss around prevention, okay? And I find that preventing cancer in general, not only breast cancer, is kind of like a little bit misleading because people feel, what could I have done? And what can I do to not allow it to come back? But would you agree that sometimes it's not the way it is? You can do, there is no preventative measure that doesn't switch on the cancer that you may get eventually in your life. So can you speak a little bit about that? Because I find that often people think that if they do things, it might prevent them to get cancer.
Yeah, that's a really great point. I'm glad you brought that up. So I can tell you, I have some of the healthiest patients. I have marathoners, I have vegans, I have patients who live very healthy, active, clean lifestyles and somehow still get breast cancer in their 30s or 40s. And there isn't even a genetic link. So you're absolutely right. There are only so many things one can do to kind of live a healthy, active life and put themselves in the best position for prevention of all kinds of cancers and other diseases. But in the end, there really is no one thing that probably caused their breast cancer. If anything, especially for the younger patients, The one thing I will say is there's probably more genetic things that exist that we just don't know about yet. So that is why a lot of people who were really young when they got breast cancer and they got tested maybe 10 years ago, we're actually encouraging them to get retested because we know more now than we knew 10 years ago.
Great, thank you. Because there is a lot, that is discussed, and oftentimes I think it's just misleading for some patients. And it leads to a very, bad feeling when somebody does recur, especially. And when we go to your slide about what is breast cancer, in terms of the cancer itself, the tumor, how long is it in a person's body? I know you mentioned that the uh, ER, not the ER positive, but the which one was
Luminal A.
no, not the luminal A. Sorry, just like the one that you said occurs
Oh,
overnight. I know
HER2.
what I'm
Yeah.
talking about.
HER2.
Yes,
Yeah. Yeah.
true.
Yeah.
Okay. So how long does somebody have it in their body before
Yeah.
it is either discovered by the person herself, and now I guess it is discovered through mammograms because we have better programming for individuals to go and get tested when, with our government programs. Can you?
So I think it depends a lot on the type of breast cancer. I mean, the bottom line is nobody really knows, right? Because it's kind of impossible to study. But it does depend on the kind of breast cancer. So those luminal A, sort of low grade, really slow growing ones, they could potentially be there for many years. Sometimes I see a woman who's quite elderly, like maybe, late 80s or early 90s, and she just detected something because she's beyond the age of mammograms. And I'm like, that's probably been there for, close to 10 years, and you just didn't know about it until now. With mammograms, we're probably catching things earlier. It's super common that I will see a woman whose first mammogram at the age of 50, although now we're doing them earlier, but first mammogram, age 50, and there's something there. And it's one of those luminal lace, and it's probably been there for, at least a few years. But it just took time to grow. And keep in mind, mammograms will only detect cancers of a certain size. Typically, we say it needs to be about 1 centimeter, unless it's highly calcified in order to be detected by a mammogram. The other types often grow faster. So I would say the HER2 positives and the triple negatives, probably more in the range of, 6-ish months that they've been there, sometimes even less, but normally like not that long for those ones.
Wow, okay, that's very interesting. Thank you. And then when we're defining staging, and I know I agree with you, that staging thing gets really, in my view, overkilled, like people hang on to that. But we know that's not the only thing that defines how you gonna be, your prognosis, etc. So let's say somebody is microscopic cells in one lymph node. Has that changed in terms of how, I mean, I'm using this as an example of how a person was treated years ago and a person is treated today? Like, did they reclassify, is what I'm asking.
Yeah, that's a really good question. So the biggest thing that's happened in terms of kind of updating the staging and catching it up to sort of, our new standards is that we now do pathologic staging. So basically what that means is that we don't stage just based on the size of the tumor. So now we consider the size of the tumor, but also the grade and also the HER2, right? Because if or whatever hormone negative, because the same size of tumor could be considered a stage 1 if it's hormone negative, or a stage 2 if it's triple negative or HER2 positive. Sorry, if it's hormone positive, I meant to say. So there's actually multiple factors that we need to consider. So that I would say that's the way that staging has changed overall.
And in terms of size, bigger seems to be alarming to people, but is it not, in fact, true that even a small tumor and an in situ tumor, the biology is what is the factor of how things will evolve?
I would say the biggest predictor, like the time when we get the most sort of nervous, you could say, is when you have lymph nodes. So, if you've got like a 2 centimeter primary versus a 3 centimeter primary, not those are not wildly different, but a 2 centimeter primary with one lymph node versus zero lymph nodes, like that becomes a much bigger difference.
Okay, okay. So it's not just biology of the tumor and what it is.
It's kind of everything, truthfully. Biology matters a lot as well. So, one lymph node in the setting of it being really strongly hormone positive, you're probably going to do oncotype, and there's a good chance it's going to come back saying low risk overall, and the endocrine therapy will take care of it. Versus, even a smaller, like I've had a patient who had like just a little 1 centimeter, but she had a lymph node and it was triple negative. Much, much, much higher risk, throwing all the chemo and everything at her.
Okay, so that kind of clarifies because I don't want the language sometimes is misunderstood. So thank you. That's a good clarification. And before I go on to the questions that are being submitted, one last thing. So when you're talking about recurrence of women 20 years plus, okay,
Mhm.
uh, and are we talking about the cancer coming back as the same feature cancer, or is it entirely, because what we'd like to understand it, is it classified a recurrence if it's the same tumor with the HR positive, everything else negative, hormone dependent, etc., or is it a recurrence if it comes back differently?
Very good question. So typically, we're talking about the same cancer coming back, meaning that first cancer that someone had was just sleeping for a long time and then woke up. The tricky thing is sometimes in the process of waking up and growing again, these tumors can actually gain a HER2 mutation. So often, if someone has a late recurrence, or even not even a late recurrence, but they have a recurrence, period, we really try to biopsy because 5 or sometimes even up to 10% of the time, you can discover HER2 positivity that wasn't there before.
Okay, thank you.
No problem.
Thank you for answering my questions. I'm going to go on to the questions that were submitted. And the first question is, does the UK predict have a radiation line item? If not, how come?
That is a great question. It doesn't. And I believe the reason is that when they include surgery there, they assume that, um, if you got a lumpectomy, you just did the radiation alongside it, versus if you did the mastectomy, by and large, you didn't need the radiation. Like that's what we consider to be equivalent in most cases is lumpectomy plus radiation or mastectomy. So, I think with things being more complicated now, it would certainly be nice to have a radiation feature to add in there, but unfortunately, it's just not there right now.
Okay, thank you. The next question is comparison of survival recurrence of patients who were on TC times 4 and letrozole versus ribociclib and letrozole.
Yeah, that is a tough one, a very tough one to answer, because there's never been any kind of direct head-to-head trials. So, when we're looking at adjuvant CDK4/6 inhibitors like ribociclib, not all those patients had to get chemotherapy. Some of them did, some of them didn't. They really just had to qualify by being high risk. So it's hard to actually make a direct comparison because there is no head-to-head. Depending on the circumstance, like, your doctor may, if you got TC because you needed TC and then went on letrozole after, they may say, look, you were high risk enough to need the chemotherapy. We should also consider the ribociclib. So, a lot of times when we don't have the studies that compare things directly, our only option is to just consider offering all the options together. And I'm not saying that that's the best approach, but that's kind of all we have to work off of.
And based on that, I think what everybody's trying to do in the medical community is to decrease treatments, especially when it comes to radiation. And we're
Mhm.
seeing that already, right? So how do you approach somebody who's going to be given the amount of medication, especially if
Yeah.
they're, diagnosed with the triple negative, they're young. I mean, things need to be done because they have an unfavorable less favorable outcome if they don't do what they do. So how is the world, how's the medical world uh, balancing this?
Mhm. So there are sometimes de-escalation studies done. There are some coming out. It's so the area where we strongly consider de-escalation and not committing to kind of full courses of treatment is often if someone has a pathologic complete response, because we know that those people have, declared themselves as doing well. Um, this does not by any means mean that, if you got a PCR, you don't need your Pembro for the rest of the year, or you don't need your trastuzumab for the rest of the year. But a lot of the studies that are investigating de-escalation tend to focus on those areas. We did talk a little bit about how, we thought 5 years of anti-hormonal was good, and then it was 10, and then now 7 seems to be the sweet spot for those higher risk patients. But I agree with you, Kathy. Unfortunately, a lot of what we do is actually stacking more and more. So, what I personally like to do, I did this the other day with one of my very young patients, is I will tell someone how strongly I recommend things, because I recognize that it's just not, she's a really young woman, she's a lawyer, like she's got young kids. And I was offering her, on top of the ovarian function suppression, which she's getting every 3 months, and I think she's on exemestane. Now I'm offering her ribociclib, and it's very overwhelming. And so I just told her, like, listen, in terms of how you should prioritize this, so the ovarian function suppression and the exemestane are, for me, like 10 out of 10 recommend to you. The letrozole, the ribociclib is not going to be as strong of a recommendation, like maybe more, a 5 or a 6 out of 10. So now those are the numbers, and it's up to you now. So she's gonna kind of take it away and think about it. But it is really important to consider, yeah, the effect of adding everything and the cost too, because they're not necessarily all paid for.
Yeah, and those are, when you say these are the numbers, that is something that is very hard on patients because numbers are hard to, justify in your headspace. Like, what's a 15%? What's a 10%?
Hmm.
Especially when we're talking chemotherapy. Sometimes those values are so little in percentage, but are actually big. And so that's very concerning because, you want to do everything you can, right? But those are things that patients, I'm sure, struggle over time, trying to make a decision. And on that, my own question is regarding the ovarectomy to
Yes.
completely, I think it could be completely, damaging any further hormones within the estrogen in your body. Where is the medical community with that now? Because I know over time it's gone here, there, and everywhere.
Yeah. So, what's that saying? When you have a hammer, everything looks like a nail, right? So it really depends on who you ask, right? So, you're going to ask me as an oncologist, I'm going to be very pro, shut down the ovaries. You're going to ask a cardiologist, they're going to be like, whoa, 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 you need estrogen for your, cholesterol and for, your heart health. And you ask a rheumatologist, they're going to say you need it for your bone health. So, I will admit that I don't tend to send a lot of patients for an oophorectomy. The only time I do is if they have BRCA, and that's a different reason. That's because they're at risk of ovarian cancer. But just for the purposes of putting someone into menopause, especially if they're like in their 30s, they're young. Um, we don't really have a good answer, even with the, injections, the chemical menopause, how long someone should be on them for. Initially, we said 2 years, and then now we're saying, okay, maybe like 3 to 5 years, but we don't know. But at least those medications are reversible, right? Like they'll last for 3 months, and then, they're mostly gone. And if your period's going to come back, it will come back. But at least, it's sort of down the road, but it's a lot. Obviously, it's irreversible, right? If you take your ovaries out.
Yes, and if somebody has their children and already, has enough, the family that they want, and they want to live for those children, will there be a time where a person is given that option to increase the overall survival?
To remove their ovaries?
Yeah.
Yeah, we do. I would say probably the ideal person for it is going to be someone who's like like you said, right? So they're done having their kids, they're kind of in their like maybe let's say mid to late 40s. So menopause is probably around the corner for them anyways, but they may have years of sort of perimenopause before it happens. That's a great candidate to just take them out and then they don't have to worry about the injections anymore.
And please further your explanation of the fallopian tubes, because there was this whole controversy when it was almost like, oh, new discovery. If your fallopian tubes were not removed at the time of your oophorectomy, it didn't make a difference. Can you just touch a little bit on that?
Yeah. Yeah. Yeah, so I'm not a gynecologist or gynecologist, but from my understanding, so if someone has BRCA, they are at quite high lifetime risk of breast cancer. Breast cancer, like well over 95%, but also fairly significant risk of ovarian cancer. There is some thought that the ovarian cancer might actually start in the fallopian tubes. So um, I don't know if like TAH, total abdominal, BSO, bilateral salpingo-oophorectomy. So yes, so that is what is typically done. So they removed both ovaries and tubes, I believe, to kind of reduce the risk of the cancer that could originate from the tubes. And also, like I know women just from, friends who are done having their kids, instead of clipping the fallopian tubes, they'll just remove them now.
Okay. Okay, thank you. I'm going to go on to the next question. Can the ribociclib be considered later after 2 years post TC times 4?
Yeah, that's a good question. So there's two parts to that. So the one is, does it work? And the second is it funded? So in terms of is it funded, I have to double check. There's a program right now by the company that makes ribociclib. I believe it has to be within a year though of either of starting your anti-hormonal treatment. And part of the reason for that is like biologically speaking, the longer out you are from your cancer surgery and your all the treatments that you've finished, the more likely it is that the cells have actually just gone to sleep in your body. And so ribociclib is what we call a cell cycle inhibitor. So when the cells are awake and are active, it kind of blocks different pathways in the life cycle of the cell to kind of kill them off. So if the majority of them 2 years later have gone to sleep, um, it may not have that much benefit.
Okay, great. I know we're running close to the time limitation, but I'd like to ask this question and for you to take your time and answer it. In terms of, do you see things really improving in terms of what's out there to help women or, cancer patients, they could be male. Do you see things in the horizon that is going to change everything we're doing now, especially the layers of medication? Because we all must be grateful that we are now treating it like, not diabetic, but, at least there are things to be done for you to, be able to live some life and potentially some quality of life as well. Where do you see this from before, now, and later on? And I'd like it more on evidence-based sort of an answer.
Okay. Oh, that's a very big question. So I would say we have certainly come a long way. If you look at where everything started, the discovery of HER2, the discovery of these genetic mutations, Oncotype came out around 2010-ish, somewhere in that time range. All these interventions, all this testing, has completely revolutionized the way that we treat breast cancer. Um, and then immunotherapy, which was started in other cancer types like melanoma and lung cancer and has now been brought into breast cancer, has made a very big difference. So where I foresee the field going, I foresee actually most cancer types treatments going, is we're going to have greater finesse in terms of what we call personalized care. So each cancer type already has features of it that allow you to personalize your treatment, whether it's you're targeting the estrogen, you're targeting the HER2, you're targeting the triple negative component, you're targeting the BRCA component. We're going to find more and more of those things. So, for example, there are these other kinds of mutations, AKT and ESR1 and PIK3CA. So a lot of the research tends to happen in the metastatic setting, which I know there's a metastatic talk in the near future. So you're going to hear a lot of this stuff. So in the metastatic setting, there's all these mutations identified, and then the patients are treated with those drugs. That's ribociclib and abemaciclib were all exclusively for the metastatic setting for a very long time. And then someone had the idea of, if it works in the metastatic setting, maybe we can give it for prevention. Why wait for recurrence? Why not just take it in a preventative way? And then it becomes studied in the adjuvant setting. So that's probably where things are going now in terms of finding more mutations like AKT, ESR1, PIK3CA, identifying those patients, and then studying and eventually giving them, if there's found to be benefit, these drugs in the preventative setting. It's hard though, because I think there's just going to be more and more on the plate. And I mean, I've already kind of gone through in the talk, like we're trying to figure out, when things were all studied like this, like we didn't study immunotherapy combined with capecitabine combined with olaparib, right? These are all separate trials. So how do you put them all together? Do you offer them all? Is there benefit to giving them all? Is it safe to give them at the same time? If not, do you sequence them? Which one comes first? It's very challenging. They're very hard questions to answer. But I do think overall, having more options is a good thing because there's just more you can offer your patients. And then they can decide what's working for them and what's not. And if someone has, I had a patient who had some, significant side effects on pembrolizumab immunotherapy, and then she had not had a PCR, and I said, well, like we could give you capecitabine because we still have that evidence from before. So yeah, I don't know. Hopefully that's a satisfying
Yeah.
response.
Yeah, because once you present such big information, it's always nice to finish it off with something that, allows us to think, okay, things are moving and
Mhm.
we're going in the right direction, hopefully. And with that, I want to say again, thank you so much for that lovely book that you put together. And of course, thank you so much for your presentations and for your great answers to my questions and the questions that were submitted. And now I'm going to conclude by saying it is time for us to conclude today's session. Thank you everyone for your questions and for joining us to learn about early stage breast cancer. And again, I want to thank you, Dr. Arora, for being here with us today. I want to thank our sponsors again, Novartis, Pfizer, Gilead, Bayer, Tessera, AstraZeneca, and Lilly Canada. Following this session, you will get a link to complete a survey to provide feedback on the session. Please consider leaving feedback as this helps us improve future sessions for attendees like yourself. Once the recording is available, Rebecca will share a link along with resources shared in today's session. And with that, thank you everyone. Have a wonderful afternoon, and thank you, Rebecca.
Thank you, everyone. Have a good afternoon.